Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh, Shalom Namo Buddhaya, greetings of welfare and peace be upon all of us. Allow me to introduce myself. I am Jonathan. I will be guiding the proceedings on this joyful event today. Before we commence, I would like to extend greetings to our esteemed teachers and the invited guests, Prof. Stephen Gatt, who have joined us in this moment. Today we are going to hear an in-depth discussion from our visiting professors, Prof. Stephen Gatt, and please join me in giving a heartfelt round of applause. This lecture is hybrid and are being streamed online at YouTube Balinesthesia channel. And there are surgeons, midwives, and also OBGYN specialists who have joined this streaming online. And this lecture will be divided into 2 lecture sessions, and all sessions will be moderated by our respected teacher, Dr. Hedita. And without any further delay, I would like to hand over the session to our moderator, Dr. Hedita.
Sir, I'm Herdita, I'm your moderator today. Oke, mungkin saya akan ceritakan sedikit untuk Prof. Steve. Kita akan membahas tentang prehabilitasi advance. Jadi ya, prehabilitasi itu adalah preconditioning atau kita mengoptimalkan kondisi pasien sebelum kita akan menjalani suatu tindakan prosedur operasi. Ya, yang kita ketahui untuk saat ini kita akan banyak menemukan teknik anestesi baru, terutama untuk ERAS atau Enhanced Recovery After Cesarean. Bagaimana kita caranya mempreconditioning atau mengoptimalkan kondisi pasien sebelumnya. Oke, Professor, the screen is yours.
As you know, I'm on your faculty over here. I have been, there's my picture, next second guy. So I'm stuck on staff here. I come usually every year. This year, I've been probably more than 45 times to Indonesia over time. I came for the first time well before you were born, 47 years ago. And some years I come once, sometimes I come twice, and sometimes I come 3 times. I've been to the surgeons, obstetricians, all over the place, Malang, Makassar, all these places, all over the place. I think Indonesia is truly one of the great undiscovered places of the world, one of the great gems. You have so much beauty in this country, and the hospitality of your people is outstanding. I'm very proud of your faculty here at Udana University. Today I want to explore 2 things. This was supposed to happen a year ago, but unfortunately my wife sustained a fatal middle meningeal artery stroke. And she's now sitting in Nusa Dua next to the pool. She is, 8 months of time in rehab, but initially it involved many days in intensive care on ventilators and helicopters and all sorts of paramedics and so on. So this was supposed to happen 1 year ago. In fact, it was supposed to be bigger than this 1 year ago. In this lecture, I want to introduce 2 things, right? The 2 things I want to introduce is ERAS, and in obstetrics that would be ERAX, cesarean section. And that's enhanced recovery from surgery, which in effect is actually a surgical concept. And the surgical concept, I think, is surgical. More close. There was more close. Now, so basically, the lecture is called Prehabilitation and ERAS, a combination made in heaven. As I said, it's a surgical concept, right? But it has been driven entirely almost by anesthesia. And now I want to introduce rehabilitation. And in fact, the lecture is all about how you can set up in your hospitals, using virtually no money at all, right? And I'll tell you about the stream a bit later on. A rehabilitation service. But let's start off, first of all, with ERAS and ERICS. It's not moving. Now, these are my disclosures. I've worked with just about every single company in the world. And I can promise you that everything I have to say today is not the book at all. I have no pecuniary interest in this. There's no companies involved in this at this stage anyway. So this presentation is purely my own approach. Okay. I don't know if you understand exactly what ERAS is all about, but Indonesia, amongst the ASEAN countries, has been one of the first people to adopt ERAS practice. Across the world, this is the flavor of all surgeons. It is loved by hospital administrators because they save a lot of money, right? Remember that almost all research done in the past in the area of surgery has always involved reduction of the length of stay. So basically, instead of coming into hospital 3 days before your operation, and then having your operation, and then spending 2 weeks in hospital in a bed, right? This has all gone. You arrive on the day of surgery, you have your operation, in 24 to 48 hours, they treat you out. This is an enormous saving across the world. We can do vastly more, bigger numbers of surgery, which is very good for anesthesia. It's actually very good money for anesthesia as well, right? Because instead of the tools, our departments have grown. My department grew. When I first started, I had 29 consultants and about 10 registrars, my trainees, guys like globally, right? By the time I finished, I had a staff of 168 consultants and 51 trained and 51 registrars giving anesthesia and paying, everything. Okay? So the ERAS protocol, in fact, involves, first of all, the pre-admission, then you go to the clinic, you have your preoperative services offered, then you have surgery and anesthesia, then you have the post-op, and then you have the ward, and then you go. And this is seen as being the recovery period until the time you go. In a lot of ways, the surgeon had to take care of mostly of this and of this, but this bit here was entirely anesthesia. We owned it, right? The preoperative services were all established within anesthesia. And unfortunately to me, the most neglected part of this ERAS protocol is this pre-admission section over here. Because in most hospitals, nothing happens in that period, right? It only starts here with the preoperative clinical. We also are not measuring very much what we're doing in this period. We don't know if ERAS for your hospital, Sangla, we do not know if how we perform. We do not know if this is better. We don't know if it's worse, right, than we had before. We don't know if we're improving every day. And what I want to produce to you here is now starting to measure outcomes in this period. This is the new flavor of the world. It started mostly in Sweden, right? And also in this area here, the power, as I'll show you in a moment, is coming mostly from Canada, and it's coming mostly from British Columbia and Vancouver, right? With regards to this section here, this again has been driven mostly by countries like Sweden and Australia. Okay, so we've got all of our pre-op clinics. They're very strong. They do a fantastic job. But I think it can be better. Now, if you think of what happens in that process with regards to implementing ERAS, and I said, ERAS has been lectured a lot. I was up in Jakarta 3 days ago, and on the bookstands I found a book about this thick in Bahasa called ERAS, E-R-A-S. So really, this is big time stuff happening here now. Okay? If you think of what anesthesia does, though, most of it has to do with this. In not giving people large amounts of opioids, so that they're almost drunk after their operations, so that they're always sitting, doing very little, really, for a number of days post-op, that they have to stay in hospital for pain. And we have many ways of doing it. Again, the perioperative fluid management is ours. The standardized anesthetic protocols are ours. And even some of this stuff, thromboembolism prophylaxis, antibiotic prophylaxis, right? Producing anesthesia for minimally invasive surgery. These are all owned by anesthesia, not by the surgeons at this stage. So what, again, in the post-operative theory, using mostly oral, non-opiate drugs for pain relief after your surgery. The rest of them, nutrition, mobilization in the post-operative period are mostly controlled by other departments, like allied health, like the physiotherapists, like the nurses on the wards, and so on. But remember that the key to all of this happening is, in the end, anesthesia. Only anesthesia can decide not to use opioids. It doesn't matter what the surgeon does. If we load them up with a lot of opioid during the anesthetic, especially if you use all the new agonists we have. But on the other hand, we have now got shorter and shorter acting opioid analogs. Remifentanil, for example, which breaks down spontaneously, has a very short half-life. There are all those things that we can do, that we do already every day in our practice. In many ways, the crux of all of this is in fact that multimodal anesthesia. We are very lucky. There is no receptor in life that we don't have. We have ketamine, which is an NMDA antagonist. We have it in intravenous form. We have COX-2 antagonists, like paracoxib, also in intravenous form. We have ibuprofen and the NSAIDs for intravenously. We have central COX-3, COX-3S, again, agents like intravenous paracetamol. We have all the opioids you can possibly ever think of, short-acting, long-acting, the lot, right, in many, many ways. And we also have things like tramadol, which are noradrenaline and 5-hydroxytryptamine antagonists. But more important than that, anesthetists have come up with this great, wonderful thing, right, where we can add, where we can add local anesthetics of all sorts, major neuraxial blocks, peripheral nerve blocks, eye blocks, anything that you can possibly think of, right? Which will then act synergistically and additively and produce better analgesia. So in many ways, we are lucky. Thousands of papers in anesthesia, and again, these places, Indonesia is lagging well behind the production of these papers, but we will get there, do not worry. Now, different surgical procedures require different mechanisms for operating. So our main role will always be to produce the best type of pain relief, for example, that we can produce. But we must tailor-make it to every single patient and every single operation. Why? Because pain comes in different types, right? It can be, and I can mention 30 places, but it can be visceral pain, it can be peripheral pain, it can be all sorts of different things. Secondly, the intensity of the pain varies dramatically. The pain from a knee replacement is about 3 times higher than it is for a hip replacement. It is much better for you to have a hip replacement in terms of pain than having a knee replacement. It's a weight-bearing joint. You have to walk on it at some stage anyway. So really, and the pain lasts a long time. Again, please stop. Yes. We have different locations of the pain. So, the pain from an eye surgery is completely different to the pain of dental surgery, for example, and so on. And I've covered these sort of aspects in the past here before. We have different risks and also different benefits from different types of techniques that we use. So the price to pay for regional anesthesia is very small compared to the great benefits you get from using local and regional anesthesia as opposed to using intravenous infusions of opioids, for example. Now, we mustn't ignore in all of this all the other things that we do, for example, but to be of rehabilitation and ERAS is that we maintain temperature control. And we do this in many, many ways, you see. We need temperature stability perioperatively, not just intraoperatively. You can't just warm up the patient. You're lucky in Bali because you don't ever have to warm up the patient. It's hot enough already. In fact, it gives me an excuse to take my jacket off in a second. But you remember that we're monitoring core temperature, we're warming the patient actively, but over here, for example, you minimize exposure of the patient most. And all of those things are meant to maintain the stability of temperature, for example, and the same can be said for hydration, the same can be said for nutrition, and so on, that are purely under control intraoperatively and in the perioperative period of our anesthesia departments. If you don't mind, I'm going to take my jacket off because it is good. Now, why do you think that ERAS and ERACs have had such wide acceptance across the world? Why? Because if I take off my hat now as an intensive care specialist, if I take off my hat as an anesthetist, and I put on my hat as a head hospital administrator, and I put on my hat as a health service manager, and I take off my hat as a obstetric medicine person, right? Then the hospital's administrators love this stuff. Why? I'll show you why. First of all, the complication rate for surgery using ERAS reduces complication rate overall by 25 to 50%. The cost to a country of having 25% reduction or 50, this is not a small print at the bottom of your page. This is not a small amount of money. This is huge amounts of wasted money. Reduces complications, and that's only by using ERAS, not even by using prehabilitation. You get much better than this, right? Hospital stay reduced again by 20 to 50%. Right? There's, post-operative opioid use is down. The increase in 5-year survival from surgery is increased by 40%. So these complications are bad news. These complications are very expensive. The saving and costs and the freeing up of hospital beds is gigantic by using ERAS. So the whole world has accepted ERAS, enhanced recovery after surgery, as a basic human right. A bit like pain relief is a basic human right, like water and food, right? And the nursing workload and staff satisfaction and patient satisfaction, straight up, right? The nurses feel better, what they're doing seems to work, what the doctors seem to be doing seems to work, right? The health service managers love this. You cannot imagine how much money they've saved in hospitals who have embraced very well. There is, however, one problem. And the problem is that these hospital administrators have no handle to play with. They forget from year to year how much things are better than 10 years ago, how much better it is than 20 years ago, because they don't measure this all the time. Now, I guess now is the time when we can do this. Again, the driving force here is the Sweden, right? And they now have something called EAS, E-I-A-S. And the perioperative team now, using ERAS protocols, has drawn up for everybody across the world, right? The EAS teams can analyze data on complications, on care duration, and all the other key metrics. We can measure these things on a daily basis, and it doesn't require very much at all. Somebody to enter some data at the beginning, and then all the rest of our monitoring and so on will give them the data that they require. But the audit tool in here, which consists of this, right, reviews and identifies areas for improvement in ERAS. So every day you can measure every single patient as they come in and see how they perform, see what the complication rates are, see how long the length of stay is. What is anesthesia doing that's going better? What is surgery doing that makes things better? And then you have a real way, and the way they do this is simple. You enter the patient data, right? And this is the auditing ERAS using EIHS. A company called NK is doing this. The software costs nothing. It costs, let me see, about 40 for the whole hospital. It costs $40,000, which is absolutely nothing. I do 109,000 operations a year in my hospital. For $40,000, I get all of those patients monitored. It's a few cents per patient, nothing, right? They then analyze the data for you, and then you can share the data with other people. You can share the data between departments, and then and now even using artificial intelligence, they can then analyze and improve on the known facts of ERAS, right, your service. So really the time has come for Sangla to adopt a system of measuring how ERAS works, of doing good things for themselves. And again, artificial intelligence, imagine if you have a system where every new patient you enter improves the analysis that you have. So it adjusts on the run every single patient that enters. And you don't just enter any patient. Every patient who is booked for surgery has to enter the database. So you're monitoring everything in every department, in ophthalmology, surgery, in neuro, in cardiac, everything is measured automatically. Now, if you look at ERAS as something that is now growing, I now start to talk about advanced ERAS. You're now auditing, you're now measuring, you're now telling people what they need to do, right? And basically, ERAS has progressed to the stage where every surgical specialty, whether it's bariatric surgery, colorectal surgery, liver surgery, pancreas surgery, breast, head and neck, gynae, urology, thoracic, cardiac, hip and knee, and everything else, right? Every other specialty now has an audit tool specific in EIAS, right? So it's done by surgical specialty. And an eye surgeon will not be entering the same data as the bariatric surgeon. See what I'm saying? That you really are improving every specialty on its own. Now, of course, one subspecialty is cesarean sections and obs and gynae, right? So let me take this as an example, because after all, my great love in the world is obstetric anesthesia, epidurals, cesarean sections. These are the ASEAN countries, right? And there's Indonesia, the gray one here, and you can see that your cesarean section rate is middle of the road, about 9%, 8-9% across the whole of Indonesia. I have a great interest in this, of course, because I'm the president of this thing, called the Obstetric Anesthesia Society of Asia and Oceania, and have been so for 35 years. I think they want to make me emeritus president. That's good. So this comes from the World Federation of Society of Anesthesia database. What is best for cesarean section? Is it a GA? Is it the spinal? Is it the combined spinal epidural, or is it an epidural? Of course, all of these things, spinal, CSC, epidural, and general anesthesia, all have their advantages and disadvantages. But of course, the big thing is that in some parts of Indonesia, they still do a lot of general anesthesia for obstetrics, which is a pity in many ways, because one of the great things is that these people have increased requirements for post-op analgesia, right, for example, where you have to use opioids and they have to stay in hospital long, whether you like it or not. And okay, there are some situations where you don't want to do regional for a variety of reasons, people with coagulopathies, for example, right? Where in those situations, it is fine to do GA. But in general, a simple spinal would do well. A simple spinal with an epidural attached to it, a CSC, even better. Right? But it can also produce some good post-op anesthesia without using any anesthesias. So in a way, ERAS fits into the protocol very well, even for cesarean section. Now, if you look at the posters that go up in every hospital, this is from Ireland, this is from the Rotunda, and basically in Ireland, in Dublin, and basically even for cesarean section, this is the ERAS protocol, which they use for cesarean section. So this is ERAS for cesarean, and you don't need to read all of this. This is cesarean delivery, this is cesarean delivery, this is pre-op, intra-op, post-op. You can still use for cesarean section and ERAS problem, which again will try and streamline the whole process for you and reduce, in my case, what happens at the Royal Hospital for Women in Sydney. What has changed about cesarean sections over the last few years? Everything. You know, I started in this game almost 50 years ago. Everything has changed. The cesarean section of today doesn't look anything like the cesarean section of 50 years ago, or 40 years ago, or 30 years ago, or 20 years ago, or 10 years ago. Everything has changed. The philosophy has changed, the drugs, the techniques, the gear, the equipment, the sequences. So basically, one thing that's very important, that ERAS for cesarean section, even under general anesthesia, comes at a very good time for us in anesthetics. Right? I couldn't have thought of anything better to do than introduce ERAS at a hospital that does only obstetric gynae. So the way, for example, of doing a cesarean section under general anesthesia, right, can be very highly complementary to ERAS principles. And I want to stop there with ERAS because, in fact, this lecture is not about ERAS at all, but it's how we extend ERAS now to prehabilitation. I don't know what your understanding of prehabilitation is, but please let me say something about where I come from in the first place. I come from an island in the Mediterranean, south of Italy, called Malta. I went to the University of Malta. I got my basic degree in Malta. Malta is smaller, is only twice the size of Nusa Dua. Right, Malta, right, is 316 square kilometers. Its population is exactly the population of Nusa Dua, right? We get 2.4 million tourists. The whole of Bali gets 15 million, but then you're also much bigger than Malta is. In fact, we have, while Nusa Dua has the same population as Malta, right? We have 2.4 million tourists every year. So our main industry, like Bali, is tourism. Our flag, this is Indonesia's, and this is Malta's flag, red and white, both of us. Right? There are 4 countries in the world that have flags that are red and white. They are Austria, Poland, Indonesia, and Malta. Right? Malta is a very, in spite of its size, is a country, a complete country. In fact, the president of the European Union is currently Maltese, and currently Malta is in the Security Council of the United Nations, because we take it in turns. Not because we've done anything special. But if you think about this, right? For example, Udayana University, right? Established 1962. University of Malta established 1592, right? And the medical school itself is 1676. I don't think Indonesia even existed in 1786. Okay, so what I'm saying is, you know, these are very old medical schools, great reputations and so on, right? But Malta is 1/3 the size of Hong Kong. Malta is half the size of Singapore. It is 10 times the size of Nusa Dua, it's true, but we're only 1/18 the size of Bali. That's how small the country is. That's how small one island, or three little islands next to each other. But tiny. One of them is 8 kilometers by 4 kilometers. This is the second biggest island. It's not. Anesthesia, though, if we come now to prehabilitation, I remember that anesthesia, right, has always controlled a number of services in hospitals. We started off about 50 years ago with running our accident and emergency services. Anesthesia was doing all the A&E services. In fact, if you think about it, every acute service that you have in your hospital is actually driven by anesthesia. 50 years ago, we started with A&E, then we went into intensive care, then went into pain management, then we went into clinical engineering and those sort of things, because we're the only people who understand the equipment, and so on. We then went to hyperbaric and diving medicine, and then we went to preoperative services. So everything in a hospital, right? Even more so because we are the only people who live in the hospital all the time, right? We don't come in like surgeons, do 2 days of work and then they go and work in the private. we're always in the hospital. Because of that, we control something even more important. We control the hospitals themselves. We control medical administration. We control health service management, right? And now anesthesia is no longer called anesthesia in most United States hospitals. It's now called anesthesia and perioperative service, right? So, and I wouldn't be surprised if in 10 years' time, we'd even drop the word anesthesia, and then anesthesia would fit in here rather than here, right? Which means that we will become perioperative services, pre-op, intra-op, post-op, right? It is simple to me that you would want to do that with anesthesia. And now comes rehabilitation. And so I think that the time has come for anesthesia to run on behalf of the surgeons and everybody else who's near us, the rehabilitation services as well. So this to me is an important item for the hospitals. It's also very important for the anesthesia departments of our world. So let me start a little bit about rehabilitation, right? What does this whole terminology mean, right? We all are aware of what happens in preoperative services. Patient comes in, you check them in, you make sure that the blood sugars are all right, right? So it's easy. In about 22 years ago, I ran a conference in Europe for the European Society of Regional Anesthesia. At that time, I invited 3 interested speakers. This guy, Henrik Gatt, the first surgeon ever to win a Nobel Prize for discovering just guess what? ERS. So the guy he comes from Copenhagen, great friend of mine, right? And Henrik Gatt had a simple theory. He says, if you want to be an athlete in the Olympic Games, you go and you do some serious training, right? You compete all day, every day, with yourself. But you come to surgery, you have half your brain taken out, or your heart damaged very seriously by some crazy surgeons, and you do nothing except put people in bed. They sit there for 2 or 3 weeks. Old, frail people, they do nothing at all to improve the services. So basically, the Danish hero, surgical hero of the world. The second was Narinder Rawal, who hasn't got a Nobel Prize, but he deserves one. He's an Indian who works in Örebro in Sweden, right? And this guy introduced both pain services and preoperative services. So a lot of the knowledge that we have about running initially peri-op. He was in Jakarta the day before yesterday with me. We went to Lombok together. We went to Jakarta together. So I see this guy at least twice a year. And the third person is this guy here, who's also that guy over there. He's on staff over here, on faculty here. He's been on staff here and faculty here, together with this guy over here. Where's Alex? Alex here. That's Prof. Chuck. This is Alex here, right? We've seen over here lecturing many, many times in the past. And basically, this guy was supposed to come here 2 weeks ago, but unfortunately, the volcano in Flores stopped his planes coming, but he will come later on this year. Don't worry, I'll bring him. He has to come. I told him, he has to. What I'm saying is that this guy is probably going to be the next and the first Nobel Prize for anesthesia. Because this guy is working on something that is so exciting to me, and he was going to bring it to you 2 weeks ago to show you what he's doing. They're working on the presynaptic membrane. Remember that, for example, the postsynaptic receptors for GABA earned the Nobel Prize, right? A guy called Eccles, not an anesthetist, right? But this guy is working on a presynaptic work, which has never been done before. Because this receptors on the presynapse is identical in every single organism on the planet. It is a receptor, not even a receptor, I guess. It is a mechanism which is so profoundly important to life. It's the only thing in every organism's body that cannot afford to have a mutation. So all mutations that happen here cause instant death. The mutation is never transmitted. down lines and so on. Right? And if this guy has what he wants, the Brain Institute in Queensland, University of Queensland, will have a reversal for all anesthesia. So at the end of your operation, you will administer a single dose of something, which is already in the pipeline, right? That will reverse all inhalation agents and all intravenous agents that you've given in anesthetics. Can you understand the implications of this? That at the end of your operation, like you reverse your neuromuscular blockers, right? Right? It will now reverse the entire anesthetic, not the neuromuscular blockers, but all the induction agents, all the maintenance agents that we use. The patient will wake up wide awake. If you're a frail, elderly person, right, who should not be even having surgery, but we have to do some operations on these people, they don't end up developing post-operative cognitive decline. They don't develop post-operative delirium. They can just go home. So take a cholecystectomy, for example. Anesthetic technique would be a spine, right? 1.2 mils of lidocaine, thoracic spine. Now, again, sweeping all over Europe. If you read the literature on anesthesia with regards to how we deal with these patients, we do it on nothing. They don't stay in the hospital. They go straight home after the cholecystectomy. So they don't develop delirium. So they have their own place where they live. In the past, they would have come into hospital. They then get a bit of post-operative delirium. Then they become confused and disoriented. And then they get sent, not home, not back home, but to a nursing home, where they will eventually die. Because by then they're so completely confused and have so much post-operative cognitive decline. Anesthesia now has the power to do all of this on 1.2 mils of lidocaine, right? So the anesthesia picture that you will be received into eventually is completely different to what it was for me when I first started in anesthesia, right? Already you have this guy, that guy, and now you can have this guy as well, all right? Now, so let's go back to that first picture I showed you at the very beginning, right? All of this is already being done, and now we have the tools for auditing the outcomes and the compliance with ERS. Easy. $40,000 multiplied by 7,000, that's what? 28.8 million. All right, and here is the place that we do. Right? The surgeon tells you you can have your upper GI surgery, your knee, your hip, whatever, done. But the first date I have to operate on you is the 28th of August. What do we all do? Nothing. On the 27th of August, give them a phone call. On the 28th of August, they come in. Everything's been prepared by then. They've had the bloods done. They've had everything done. And then you have your surgery. So until they come here into pre-admission and peri-op, we waste 8 months of making the patients better. And this is what prehabilitation is all about. Not wasting this time, the weeks, sometimes even months, sometimes even years. Instead of improving the patient every day, all the time, right? We do nothing. Right? And yet the savings for the country and the usefulness of this period is fantastic. The opportunity to even cancel operations, because those patients don't even need them anymore. The opportunity to be able to improve them is so vast. Now, if I asked you, what would you improve in a patient, right, before surgery? Okay, Heinrich Kelly said exercise, you know, but there's so much more that we can do. So much more, right? For example, we can fix up their anemia, right? Let's say, I'll show you this in a moment, right? You can fix up their anemia, right? How do we fix up anemia? Most of it is iron deficiency. And in Bali, it is especially prevalent, especially among the poorer people in the country. All it takes is 1 needle of ferric carboxymaltose to reverse immediately within a week all anemic. So the rule in Sydney now is nobody comes to cesarean section with a hemoglobin of less than 12. In Africa, people die for lack of one single unit of blood because of their anemia. 1 unit of blood is all it would take to save those lives. Thousands of people. I'm not joking. This is really big stuff. Again, substance abuse. Can we do anything to correct the substance abuse that's going on? Of course we can, right? Some people will think it's desirable, but for the time before your surgery, let's stop that stuff. Let's give you some good alternatives. Let's, we'll even buy you some dexamphetamines, medicinal, so that you don't have to buy crack, and you don't have to buy ice, and you don't have to buy crystal meth, right? Because we can give you a script for something that is a bit better, perhaps. Again, the cardiac condition. If they're in heart failure, don't bring them to surgery already with cardiac impairment. Try and improve the heart surgery, right? Try to improve the way they operate. Frailty. I've just told you how easy it is to correct frailty. How we can make them better and better enough before surgery, that when we operate on them, they don't end up in a nursing home. Again, diabetics. How can we make sure that the glycemia control has been done 2 months before, and every day they're receiving the right doses of metformin, of insulins, of all those things, right? Right? And I'll show you a bit more about this. Again, physical activity and mobility, pain management before surgery. These people who have bilateral knee replacements, for example, are in absolute agony every day. And yet we can do so much to reduce that pain for them before the surgery. But it isn't just those. Even the fact that they understand what we're going to use after the surgery. We have 3 months sometimes, 2 months to be able to do all this work. And I tell you, you work in a public hospital, but can you imagine the aesthetic surgeons that are working next door in a private facility, right? If they could get their patients from wherever they're coming, usually from Hong Kong and Singapore and Thailand, places like that, the Russians now, right? They want to come to Bali, because Bali is a nice place, right? They want to have their breast reductions, their breast augmentations, blah, 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 right? Can you imagine if the hospital was able to offer them a prehabilitation service where even if they're in Russia, they can actually have all this stuff done for them, right, before they came. This makes a reputation of a private hospital, right? Absolutely fantastic. The Australians have built 2 hospitals recently in Bali, right? One is finished and one is on the way. All of these hospitals will definitely have a rehabilitation service. And you will go in those hospitals, right? All of them, right? Nutrition. Why would you want to operate on a poorly nourished patient? The cost of giving them good nutrition is tiny compared to the advantages that you will get from 2 months of making every single person who's of poor socioeconomic group every day. How will you do this? You give them a box of these sort of things, right? This is what I use in Australia, and it's made by Nestle in the USA, and this is what I use over here, right? Made by the you give them 1 of these 2 a day for the time that you have before your operation. A very poor person who can't afford to even eat decently every day will suddenly come in peak nutritional condition. It has everything. It's almost staggering. I'm feeding. If I give my wife the stuff, my wife currently, so I'm feeding her with the stuff. Look at the contents of the stuff. Look at what's in it. Right? There's everything under the sun. I could keep my wife with 3 of these a day alive for 4 years. And all I need to add to it is water. That's all. So she used to have regular. And the same with this. This stuff you can actually buy from your local gym. Right? So all the big athletes are almost having 1 of those a day. In my wife's case, I give her 3 of those a day. Right? Because she's a super athlete. She survived the stroke. Right? Sorry. I go back. Again, smoking cessation. In Bali, you still have to. But if you had 2 months and you gave them everything that they needed, you give them nicotine patches, you give them vapes if they want to, give give them something stupid, but get them off the smoking. It doesn't matter if they only stopped the smoking for 2 months before the surgery. They went back to smoking 30 packets a day and wasting their life. Most of the time, you will be curing these people forever from their smoking, right? But we have to provide them with the tools to do that. Again, social supports. Many people are lonely when they come to anesthesia. They don't know where to go after the surgery is done. They have the surgery sometimes for social reasons, and not for anything else. And the hospital next door, where people are just having tummy tucks and bottom tucks and breast augmentations, all of these people, all they need really is a lot of social support. Tell them that their breasts will go right. I do some of this plastic surgery for cancer patients, where we remove their breasts and then they have to have a breast implant, for example. All of those people with social supports sometimes don't even want the surgery. They can wear a special bra or something. Sleep apnea, again, one of the great killers of modern medicine. Right? How do you do this? How do you stop sleep apnea? It's easy. You send them to the sleep apnea clinic. They might organize a CPAP machine or whatever is important, but they don't come to surgery 3 months later with the sleep apnea. Anxiety. Look at how much stress this happens, right? And causes anxiety amongst our patients. This is why the patient satisfaction of rehabilitated patients is so much better. This is why the hospital develops a great reputation of being a great hospital. This is why it makes doctors happy and medical administrators happy. Again, obesity, luckily for you, you don't see the obesity I used to see in Boston, for example, at Harvard University. I'm talking 280 kilos, right? That makes six of you, right? In one body. They couldn't even come in with ambulance because they break the beds in the ambulances. We brought them in the laundry truck where we bring in the laundry. This is how big these people are. Given 3 months, you could reduce the risks of obesity dramatically. Again, but we have to produce the right tools. Now, how do you do all this when you start with nothing? What I want to show you now is probably one of the most dramatic things that has happened in surgery and anesthesia in this area for the last 4 years, 5 months. I've just come back from the World Congress of Prehabilitation, which was held in Melbourne. And the British Columbians, these guys, have produced a complete set of documents, right, that everybody can have for free. You can translate it into Bahasa. You can translate it in any. You want to convert it in Timor to Teton, you can do that. It doesn't matter, right? But this is how to do it. It's a kit, right? If everybody in the hospital had one of these, it would change everything. It even tells you how to get the funding, the money for these things. These things don't have to be funded by hospitals. These guys who sell you this stuff are more than happy to support these funding mechanisms for building your right? Yeah. And these can be translated into any language free of charge. You can do them in whatever format you want. You can make them look pretty. This is the toolkit, right? So this is how to make, this lecture should probably have been called how to make your own rehabilitation units with very few resources. You might say, well, when are we going to get all these doctors to do this? This is stuff that's not done by doctors. This is stuff that's done by patients. This is not stuff that's done by allied health, except perhaps putting a Zoom meeting on for the day, and they can do their exercises at home using simple things like TheraBands and so on, right? And now we come to the passport. These guys, right? These guys have even given us a set of cards like this, which I'm going to give to your chief resident, on how to actually change anything that you want to in your hospital. There you are, my friend. Nadia, something for you, my friend. There are a set of cards on how to implement anything that you want to in your hospital. It's basically a set of cards on change, of how to do change, right? I haven't given it to one of your professors because they'll probably put it in the library and then forget about it. chief resident told me that, right? But now we come to probably the most important part of all of this, and it's that. The patient, in whatever language you want to, right, can be given a passport. This is the passport, right? It's a book. And I'll show you in a moment. Each page corrects all the things I've just shown. It corrects obesity. It corrects, right? The stick here, right? Or perhaps I should tell you about the carrot. The carrot is that they will be better for the surgery when they arrive, right, in the hospital. But the stick is that if your surgeon tells you that you can have your surgery on the 25th of August, and you don't stop smoking, and you don't reduce your weight, and you don't do all those things, then your surgery is postponed. It gives space to somebody who has decided to make things better. Whatever. So it doesn't impose on the country 40% more complications. So instead of being given 25th of August, they'll have to wait 5th of December before they can have the surgery, so they can do their post. Right? So in many ways, this thing will always work. A, because it's in the interest of the patient, but it's also in the interest of us. I want to walk you through what's in this passport. So as soon as the surgeon says you are having an operation, he will give you one of these. You will take it down to the prehabilitation unit or the peri-op service, right? And then they'll say, are you obese? No. Cut that page off. Are you anxious? No. Cut that page off. Are you diabetic? Yes. Okay, we then put you on the glycemia control project. We get an endocrinology registrar resident to see you, right? And then we decide on a plan for 2 months as to how we're going to improve your plan. Simple as that. Okay? And this is, for example, what it looks like for anxiety, for example, right? If you have any anxiety about your surgery, if you have panic attacks, if you have all of those sort of things, the program says, to optimize my anxiety, I have met with a primary care provider regarding mental health. I have met with a psychiatrist or psychologist regarding my mental health. And we tick the box, I've had a discussion with a healthcare professional about my thoughts and worries related to surgery. I have attended counseling, and not everybody will need this. The milder ones won't need counseling at all, right? Most of them will not even require medication to control this, right? But at least they've been seen, and we know what the levels of anxiety are going to be when they started and when they come back to surgery. Right? Anyway, and so it goes on. Once you tick your passport, after prehabilitation, I have used one or more of the items, yes or no, and I now have some additional questions, and there's another blank page after this to show how to do this. This is, for example, nutrition. I've already shown you microbottles. We actually tend to use not those things, but this stuff. It's called MediDrink. And this MediDrink is specific for almost everything you can think of. There's one called peri-op, or pre-op rather, right? But there are others, right? For celiacs, others for pregnancy, others for all sorts of things. Peri-op. Upload, so that basically will ramp up really in the last 3 days or 4 days. We can upload. Before that, we have platinum. Again, there's stuff for kids, so really good kids, hundreds of products. But again, very much a sort of format, right? The hospital just gives these patients the appropriate drug. They give them a crate, take home with them. It'll have 15 or I think a pack is 20. They give them 20 of these. They've got 20 days supply, right, from the hospital pharmacy. The cheapest price they can get, the hospital pharmacists can get it at. And the benefits are that when they get to hospital, even if they don't even have the surgery, it doesn't matter. These are people who are malnourished in the first place. Imagine if you could put this sort of stuff in Gaza, apparently, or in Ukraine, right? Again, physical activity, right? Now, you can do the really expensive stuff. You can buy machineries like the new Noemi, which I was going to bring actually a year ago over here, to show you how, if you only have a very short period of time, like 3 days, 5 days before surgery, you can put machinery that's used in gyms by weightlifters and bodybuilders to increase muscle mass. In very old people, it's like magic. You know, they go for almost nothing. This is stuff that's been used by Andre Agassi, right? And Ivan Lendl, for example, to repair muscle injury, right? So this is really very high. But those are expensive devices. We don't have to use anything like that. We can use simply bits of rubber, terabytes, right? We don't have to bring them to the hospital every day. They do these things at home. Or if they can afford a bit more money, they do them at the gym. But they don't have to do anything special. We just tell them what exercises are appropriate for what surgery they're having, or for what you need to do with them. So basically, this newbie, or noibie perhaps, is pulse current stimulation for prehabilitation, for muscle strength, and muscle building before surgery. Can you imagine a person with poor balance, right? A person who's elderly, a person who's now starting to waste muscle because they're always sitting in front of television doing nothing. Suddenly you give them 2 months of this. And I tell you, by the time they get to surgery, they probably don't need the surgery, right? The number of days, you know, so this is so basically, number of days a week I exercise, number of minutes I exercise a day, and number of minutes in a week that I exercise. And the goal is 150 minutes per week. It's not a lot of time. 150 minutes per week, right? It's 20 minutes a day, basically 25 minutes a day, right? Before your surgery. If you already are doing that exercise is up, you don't have to do anything at all. They're doing enough for themselves already. You've met with a primary care provider, usually not an anesthetist, usually not a surgeon, but usually somebody from the physiotherapy department or from the occupational therapy department, right? You've met with a physiotherapist or a kinesiologist, these are the movement people. You've accessed, in their case, HealthLink, British Columbia in Canada. You have know about the physical activity guidelines of Indonesia, for example, right? And then you complete a 6-minute walk test to see how well you are. Again, you can buy other very expensive equipment to this, and we do it again at the end of surgery. So after prehabilitation, I exercise now for 25 minutes per day, in a day 25 minutes, a week 150 goal, and the number of days that I exercise. Simple as that. That's the only thing that this passport tells you to do in the section called activity. Right? Substance. Every page of this is pure physical activity, social support. That's what's in the pain management. That's what's in the passport. Anemia. Right? Anemia, when I was a boy, and taking iron tablets for the whole pregnancy, right? For example, every day for the whole pregnancy, just about, right? Nowadays, it takes 20-minute injection. You have to put it in a bit slowly, but it can be done by your local doctor. Little butterfly needle, one stuff called the stuff, ferrocarboxymaltose. That's the ferritin levels here, right? And this is the red one is iron carboxymaltose. Look what happens. This is ferrous sulfide, right? Given by tablets. This is a line like this. It never changes. And the ferritin levels within this is screening, baseline, 1 week, 2 weeks, 3 weeks, 4 weeks. Within less than a week, the ferritin levels are many times higher than taking 6 months, right, of iron tablets every morning, with all the hazards and all the nausea and all the constipation that iron causes every day. Cost, now very cheap. Very cheap. Right? And then the effects are immediate. And this is why I say, at the Royal Hospital, no woman is allowed to come here this with a hemoglobin test. As soon as an obstetrician now finds a patient who has a hemoglobin of 9, 10, 11, so on, immediately sends either does it in their rooms or they do it, or they send it to the doctor to give it ferrocarboxy, which is known in my country as failed. But look at the protocol for this. My hemoglobin at the time of my referral for surgery was 10 grams per liter. My ferritin concentration was so many micrograms per mil. The date of the measurement, and here are the levels of ferritin, right? For example, patient starts with very close to 0 almost, right? And then within a week, it's now 550, right? I've been prescribed intravenous iron, yes. Have I been prescribed oral iron, right? Sure, that's if what you have is oral iron, then give them the iron tablets, by all means. But after prehabilitation, and coming to TFS, the service section, my hemoglobin is now 13.5. Easier. Again, frailty. As I said, I've just finished last year a Masters of Science in perioperative geriatric medicine. When you're my age, 73, you don't want to be doing epidurals anymore in the middle of the night. I didn't think that if I don't do cesarean sections, I should do something different. Right, so I chose geriatrics, right? Geriatric anesthesia. Again, with frail people, right? What do? Right? I met with a primary care physician, yes, about my frailty. I met with a geriatrician, and I have somebody who's taking care of me with my frailty. I've got a physiotherapist or occupational therapist who's taking care of me, yes, no, doesn't matter. But we will make things better for you, right? Have I got some goals of care? Now remember that with very frail people, we don't operate on them at all, unless we really have to. But the emergency is bowel obstructions, stones in the bile ducts, and so on. They're always going to happen, right? We can't not say we will not do surgery on them, but very most might be able to postpone everything by 1 day. So frail people will always have anesthesia, regardless of who we think they are. The amount of materials that is produced for these, for example, this one here comes from a company called Antantefit, where you can measure with a patient who's frail, who only has to make 3 steps, like that, 1, 2, 3, what their level of exercise fitness is. Right? Again, expensive gear, but you only have to have one in the unit on the day when they arrive. That's all. And one at the end, perhaps, later on. Okay, again, all of this material is available from the trade, free of charge. Right? All of British Columbia's work is available to everybody in the world. And it's shareware. It's free. Right? We don't have to pay anything for it. We're very happy to share their systems with the world. Now, of course, every hospital and every specialty will devise its own methodologies. For example, the cardiac guys, right, have a limited number of things that they're doing so far. There's some of them have nutritional programs, some of them have behavioral problems, and some of them have exercise. And some of it is just respiratory muscle training, strength training, aerobic exercise, and so on. Some of them will only have, for example, micronutrient concentrations, glycemia optimization. So every hospital will have its own. And this comes from, right, a group that does cardiac, basically, right? What does the exercise do to people? And your metabolic cards and so on, right? It measures, right, how you will do after surgery or during surgery, how we will perform. That's all it does. It's just measurement. But if we can do something in prehabilitation which will then improve it, we fix the main aims of the cardiac unit. Now, don't forget that this, in fact, is not an anesthesia service. Technically speaking, it's a surgical service being done to improve the treatment. What's anesthesia about? Anesthesia is about optimizing care for the surgical patient. So this is just right down our alley, but you require multidisciplinary teams. To give you some examples of this, right, you need, for this you need, for example, not just a multidisciplinary team, but somewhere where you can, you can look at the evidence, what I call EIAS. You then would normally have to extract all the recommendations, put them together. Over here, it's been done for you already. We then have to go to a consensus process. You see, say, a multidisciplinary clinician panel. You then have to get all your paperwork done up and get all your documents, and then you would want to consult with the patients. By using just these two documents alone and the pack of cards are available, right? It's all done. Nothing. You don't have to do anything. It's all been done. Right? So all of this process, from now on, the multidisciplinary team now knows exactly what to do. If you want exercise, you send them to your allied health people, to your kinesiologists. That department will take care of the exercise. The endocrinologists can take care of the glycemia control. Right? The psychiatrists and psychologists can take care of. These are departments that you already have in your hospitals, as it is. So we don't have to do a great deal. And I now want to conclude. Martin Luther King said, "I have a dream." And Stephen Gatt has a dream as well. That this dream is about establishing rehabilitation across all hospitals in Indonesia. I've had good record. I've been to speak to the Minister for Health, not about this, but for example, 24 years ago, as president of ASAO, I joined up with Susilo, Chandra, and we formed this thing called Balinesthesia. This has had a conference every year, which I went to last week, right? I've gone to all of the meetings. At the 7-year mark, the Minister for Health, who at the time was a surgeon, has requested that all anesthetists in the country, 2 years out of 3, come to Jakarta. The government would pay for them and for their spouses, their wives and their husbands, right? They go shopping, go do whatever they want to in Jakarta, right? Give them a hotel, not 5-star like mine, but 3-star for everybody else, right? And he would pay all the airfares. So effectively, no registration, no airfares, 3-day holiday for most of the spouses, right? It's come to anesthesia, and now it's extended to the surgeons as well. That was about 16 years ago. The surgeons can avail themselves of an indoor surgery meeting where all the obs and gynae guys would go with the obstetric anesthetist, blah, 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 and at the same time. 2 years you came to the conference, the 3rd year you stayed at home up in Sangla holding the fort. But of course, most of 2/3 of your obstetricians would be gone anyway, so there's not a lot of work. Right? In either case, those guys don't do much work. Now, you say, why didn't I come last year and tell you all of this? Basically, because my wife had a stroke, and this is what my months of March and April and June have looked like. Right? I could not, I was paralyzed, absolutely. She went from being on a ventilator and absolutely useless, and now she's walking, she's not talking, but she's walking, she's not swallowing, she's starting to get weaned off. Right? So what I'm saying is, this is why I did not come last year, to bring this whole thing. In fact, it was supposed to be even bigger, because all of these guys that do this sort of stuff, including the Indonesians, right? Companies that are very well known to you, Pexa Medica, for example, probably the biggest distributor of medications for anesthesia in Indonesia, are very, very keen to come and take part in this. They will come and support us, including in anesthesia. Right? So I'm sorry that this has happened, but that's how life is. And what is this dream I have? And can I do it? So I've told you already that I actually, if I go back, we've done much more than that actually over the years. 40 years ago, I invented this thing. So this is this one, anesthesia, and this is my society of clinic anesthesia. Right? That was about 30 years ago, almost 40 years ago, that I established and became the president. This has every single great obstetric anesthetist from every country, from Iran, and from Myanmar, and from Laos, and Cambodia. All of these belong to this society, right? They are the leaders of every country, right? In Indonesia, I have some very great people. Right? In Bali, right, these two guys, I told you, this guy at least, and this guy has done dramatic things for this university, right? Every single paper that we write, right? This guy has written 580 scientific papers. I'm nudging 300, right? So I'm nudging 300, 500 maybe. All of them have had University of New South Wales, University of Queensland, unfortunately, University. All the papers that have come out for us in that fact.
I'm sorry, Professor. You have.
Only 5 minutes. Stop. Okay, let's go. No. Right, so, in fact, this is the last slide. So, basically, I want to elucidate the dream. And the dream is this. That first of all, we set up 3 centers of health, of ERAS, CREX, and Prehabilitation in 3 places. In Lampung, in Sumatra, over here, and in Jakarta, at Chipre. Right now, Mango Fusu. I hate the way that you convert Sangha Hospital to Professor Dr. Anyway, the funding, as I said, will come entirely from drug companies, from equipment companies, from all of those sort of things, medication companies. We will convert all of these documents to whatever languages you think, Bahasa. We will engage surgeons and allied health to provide simple service in every single hospital, however big or small. The smaller you are, the smaller the service. The bigger you are, the bigger the service. But again, you pay nothing almost for what you get. You involve the clinics, right? All hospitals and clinical services that do surgery, regardless of whether they want to do it or not, because they lose their reputations if they don't do it. They have more complications if they don't do it. The patients get to know that if you don't implement this, then your chances of having a complication is 40% more just with ERAX, and probably another 40% on top of that with prehabilitation, right? You're at increased risk of complications. And this has been made known across the country. The next one is leadership, right? And the leadership, I think, should become us, should become our preoperative services, which are now being called perioperative services. The leadership should come from within anesthesia, basically, to drive all of this. But we will do it in combination with the surgeons, who will get the major benefits of this, and the surgical services, right? And also allied health, who finally will be utilized well to improve patients, all of them, as opposed to improving only the people who have something wrong with them, the multiple sclerosis, the motor neuron disease people, the people who have strokes. We have huge rehabilitation services across every one single of our hospitals, whatever we think about. Mine have been superb in helping my wife. And because I only have 5 minutes of time, I think I want to stop there, because I've now got only 2 minutes of time for questions. But I hope that went well. Terima kasih atas perhatian Anda.
Thank you, Professor. Thank you for information presentation, insightful. Okay, I will make a little bit summary in Indonesian first, Professor.
Have you noticed I've left only 2 minutes for question? Right. So basically, you better come fast, but that's about it.
Ya. Oke, jadi saya sedikit menyapa teman-teman yang mengikuti webinar juga. Jadi saya sedikit menyimpulkan bahwa pada kondisi ini ERAS gitu, tidak hanya perspektif kita itu pada hanya anestesi durante op dan juga kecepatan operator atau tindakan operasi saja yang menentukan outcome dari sebuah pasien. Yang membuat outcome dia bisa memperpendek lama rawat itu salah satunya adalah kondisi pasien. Ya, kondisi pasien sendiri juga berpengaruh sangat tinggi untuk keberhasilan kita melakukan metode ERAS ataupun ERAX. Namun ada beberapa preconditioning yang dapat kita lakukan, seperti kita meningkatkan status fisiknya dengan cara prehabilitasi, setelah itu juga memperbaiki status nutrisi pasien. Itu juga perlu jadi perhatian khusus dari kita untuk optimalkan sebelum kita melakukan tindakan operasi. Itu sangat dari Swedia tadi juga dikatakan bahwa itu sudah ada datanya loh, bahwa beberapa preconditioning yang dilakukan itu sangat memperbaiki outcome dari pasien. Untuk itu kita langsung ke sesi tanya jawab dulu. Kita akan mempersilahkan mungkin maybe 2 question first. bisa dimulai dari sekarang ya.
Listen to him. Whatever he says is exactly right. My okay,
Gitu ya.
question time. Anybody? Go. There you go. Not into silence. Fantastic.
Mungkin ada yang punya pertanyaan, nanti kita bisa bantu translatekan ke bahasa Inggris mungkin, atau ada yang bingung. Mungkin ada yang tanya tentang ERAX, maksudnya apa sih preconditioning harus dilakukan atau apa yang perlu. Oh ya, Ian.
Thank you for the chance. I will ask about the IRAX and IRAX. The first, what the contraindication for this protocol, IRAX and IRAX, and the second question is, how about the rules of fasting to successfully IRAX and IRAX? Yes, thank you.
These are very good questions. First of all, are there any contraindications to ERAS? There are none, but there are many. Because ERAS is to be modified for every patient in a way, right? It's not to be modified for a service in any way by ignoring it. See what I'm saying? So you have to implement ERAS, whether you like it or not. This is a country policy. This is a health department policy for Indonesia, right? So you can't avoid it, but you can modify it for your hospital, and you can modify it in such a way that you don't ignore it, because now you have auditing. Now, with regards to fasting, the fasting rules have changed dramatically in almost everything. In obstetrics, for example, for cesarean section, right? In the past, we used to be very rigid about nothing to eat or drink for 6 hours, blah, 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 right? We now know that, especially in children, hydration is very important, and it needs to come up very, very close. The smaller the child, the more the hydration has to be kept up, right? So now we allow even 1 hour, especially with things like water, especially with things that are clear fluids, that the worries of aspiration aren't there, right? My greatest claim to fame in anesthesia is that I'm the second author on the Balinesthesia school. So every time you see Balinesthesia in Australia, we call it Balinesthesia Gatt, right? It's the single most cited paper in anesthesia for all time, right? What did it replace? Cricoid pressure, right? The Selig maneuver. Nowadays, we realize that the Selig maneuver sometimes can be more dangerous, right? So the cricoid pressure can make intubation more difficult, for example. Okay, so again, with everything else in medicine, it's all about risk-benefit ratio. In some patients, you want to go for long fasting times. In some patients, you want to go to shorter fasting times. If they're having eye surgery and they happen to be 78 years old and they're a bit frail, perhaps, or it's not even frail, then you might want to leave it for an hour. They're going to have the cataracts done under an eye block anyway. Why do you want to alter the patterns of fasting? Right? They're not going to aspirate. They're going to be wide awake when they're having their surgery. So anyway, while the fasting regimens are all different for every service, you know, if you have people, for example, having gastroscopies, sure you want to fast. You don't want to, again, if they're having panendoscopies, you want to fast them anyway because you want to clear the bowels, right? So they can do a decent endoscopy. So what is the answer to fasting? I think the fasting is that the hospital will have to decide for every service what anesthesia thinks is reasonable for those patients. And then to be able to make exceptions in certain situations, right? Okay. How do we induce patients? In the past, we used sucks, which increased dramatically the risk of aspiration. And then we had to put cricoid pressure on, right? We now don't do that. We do very gentle ventilation, or perhaps we even do high flow oxygen for cesarean sections, for example, which again, and they're having epidurals done. So do they need to fast? Yes, I would fast them, sure. But again, what is the effect going to be in utero on a fetus when mom hasn't drunk for 6 hours, 8 hours, sometimes overnight? And sometimes the operation gets delayed and then they don't have any hydration at all, virtually, for 24 hours sometimes for some surgeries. So I think it's a very pertinent question as to how we should go with things like fasting. I think fasting needs to remain fluid at all times. Okay, now I'll stop there with the questions because I need to go. We need to go and have a drink. But we'll come back in about half an hour. The second session has nothing to do at all with rehabilitation. It's more obstetric, so more interest, not just interest to us, but interest to midwives, interest to obstetricians, and so on. Okay, but also to anesthesia, and it's to do with sudden deaths. Why do people die in pregnancy? Why do people die in labor and delivery when we don't even think that they ever have a risk of dying? These deaths are unanticipated. They're unplanned. We never think in our wildest dreams that these people will ever die. Why does it happen? So it's a very interesting talk. I talked about this about 6 years ago. So all those old guys might have seen some of these slides before. Okay? So we'll see you in half an hour. Okay? Good. Right. Eat. Have sex. So. All right. Good.
Thank you, Professor.
With cesarean section, right? With preeclampsia is a disease which starts very early in pregnancy. Unfortunately, the name of the disease is a very bad one because it assumes that all of them are in a situation where they're going to have a convulsion, whereas in fact very few people have a convulsion at all, right? And some of them have very severe disease. They develop severe comorbidities in terms of hematological disorders with massive bleeding and things like that, right? Basically, preeclampsia is a multi-organ system disease. It's a bit like diabetes, right? It hits everything. And whatever is the weak point, if it's your brain, you hemorrhage into your brain. If you're hematologically compromised already, then that's where the biggest effect is. How is preeclampsia defined, after all? It's defined with proteinuria, for example, right? With high blood pressure. Remember that in life, if all you have is a hammer, then everything looks like a nail. 50 years ago, we were measuring blood pressure. So the diseases of 50 years ago, and 40 years ago, and 100 years ago are all hypertensive diseases. This is not a disease that causes hypertension. This is a disease that causes everything else wrong with your body. Right? It's a multi-organ system failure. What we're interested in fact, hemodynamically, is not blood pressure at all. It's flow. But vasospasm caused by thromboblastic disease is actually, right, manifested best by showing high blood pressure, but all your arteries are in spasm. How do you treat that? Right? How do we treat high blood pressure in the past? How do we treat heart failure from high blood pressure in the past? By bleeding people, thrombectomy, by giving them diuretics, and they spend their time peeing everywhere. Right? This is nonsense. This is rubbish. If you have a pipe that's this size, and you have a blood pressure slab, 120 on 80. It's the pulse pressure, in fact, that makes all the difference. But if you have pipe this size, the flow is going to be very poor. Anyway, whatever blood pressure you have. If on the other hand, you can give whatever, ACE inhibitors, calcium channel blockers, whatever, and you make the pipe go from this size to this size, and you dilate them, right? Then you can have a hell of a lot more flow for a much lower blood pressure, right? Remember, pi r squared, the area of a blood vessel, right, is pi radius squared. So the enormous amount of improvement that you produce in a blood vessel is not double or treble. If you go from this to this, the flow will increase tenfold for the same head of pressure. But we still talk of hypertensive diseases. We still talk of preeclampsia, right? And this is why I say all the diseases that we currently have are grossly misnamed. Diabetes, type 1, type 2, what rubbish. They're two different diseases. They have no comparison with each other at all. The way you treat them, okay, they both involve the pancreas, perhaps, right? Type 2 problem doesn't involve the pancreas at all. It's a different type of autoimmune disease. Okay, so what I'm saying is, we need to be very careful in dealing, Dr. What was the name? With Donna, right? We have to be very careful with our terminology. So yes, can eaters do something for preeclampsia? Yeah, sure. But obstetric anesthetists do it every day of their lives in our women's hospitals. Okay? Terima kasih.
Okay, thank you, Professor. Maybe we will take a break for second topic in 15 minutes. 15 minutes, okay? Okay, we will back after the break. Thank you. Kita akan melanjutkan sesi kedua dari topik kita hari ini. Sebelumnya saya juga ingin menyapa untuk teman-teman yang join di webinar kami. Kami akan melanjutkan ke sesi yang kedua. Nanti akan diberikan waktu kurang lebih satu sesi seperti tadi 60 menit dengan sesi tanya jawab kurang lebih 2 pertanyaan dari setiap sesinya. Oke. Jadi supaya tidak membuang waktu, mari kita mulai. Professor, we can start the second stage.
Thank you very much. This has completely different to the one I gave you before, because I want to convince you that people die sometimes when you least expect it in anesthesia. They die for reasons that are unknown to you, and you can do nothing about them. Why? Because we do not know what we do not know. Because our limitations of our knowledge is a certain spot. There are diseases that we know nothing about. There are processes that we know nothing about. Some of them are genetic. Who dies for a reason. Okay, the certificate says acute myocardial infarction, right? Those sort of things. But why the acute myocardial infarction in the first place? When they're healthy, they're 25-year-olds and they're pregnant or they're in labor. Why do people suddenly die, right? So this is like cardiomyopathies, for example. Why do people in obstetrics die when you've done everything you do and had good management? I'm the president of this organization, right? And this organization is represented by the heads of all departments in every country in Asia. The small ones, Laos and Cambodia, as I told you before, but also the big things, India and China and Australia, those sort of things, right? And in every country, obstetrics is practiced very differently, right? But why do people in these countries still die, right? For example, not obstetric anesthesia, in sport. These are sudden deaths in high functioning athletes who suddenly drop dead, right? Example, them, right, are hypertrophic obstructive cardiomyopathy, HOCM. Okay? These are people who have a thickened left ventricular wall, right, which then actually chokes the heart, so you end up with zero cardiac output and you suddenly die, right? And these happen usually at points of high exertion in sport, and they suddenly die of this disease if nobody knows about it in the first place. Some of them are congenital coronary. I'm not talking cardiac now, I'm talking coronary artery anomalies, right? But others are dilated cardiomyopathies, myocarditis, sometimes viral, in the sport, a ruptured aorta, again, a mildly increased muscle cardiac variance, HOCM, hypertrophic obstructive cardiomyopathy. Okay, so it happens in sport. Indeed, you know, in my adolescence, I was aware of a sudden female unexpected death in my sport, which is water polo, right? My sport, water polo. At 74, you don't get to do water polo much. But anyway, what I'm saying is, in a water polo match, somebody suddenly dies in the water. You know, nobody thought she was unwell, but it's happened itself. At a football match, right? This is, I mean, soccer football, not Australian type football, right? I suddenly have what they said was a cardiac arrest. I survived that, and because of that, again, the Sky Blues, I was in the news, right? You get a free T-shirt from a football team if you survive your cardiac arrest. If you die, they don't give you a T-shirt, right? So it's important instead. But at the time of the cardiac arrest, there was no troponin rise, there was no evidence of infarction, the cardiac echo was normal. So probably all we could say is that I probably had a either a fit or a respiratory obstruction from a chicken of some sort that I was eating, or chips, right? Again, completely unusual that suddenly this should happen. And it was newspaper, my house afterwards, publicity in the newspapers. So this is a good way to get yourself into the Bali Post if you want to. You know, so I've even seen unexplained deaths or close misses in obstetrics. Again, I don't know if you received this television program. It's called The Wiggles. The Wiggles are for children, and they dance. It's programs basically. But one of the Wiggles, right, halfway through a program, suddenly had a cardiac arrest. Healthy guy, jumping up and down on the stairs, suddenly had a cardiac arrest. He was in a bushfire relief show, right, to help people who've had bushfires and raise money for the bushfire people. Suddenly has a cardiac arrest. So this happened only last week. I sent to my cardiologist my referral slip to go to a specialist, and I sent this guy in here with this disease. It's called Flamen C, dysrhythmogenic or arrhythmogenic left ventricular cardiomyopathy. This is a genetic thing. His father died at age 39. Suddenly, they said his heart exploded, and that's exactly what happened. If you have this particular variant of Flamen C in your genes, the fibers in your heart are usually attached to each other, and they've got this little bit of sticky stuff in between so that they don't fall apart. These guys can't form those things. It doesn't affect the heart at all for many, many years, right? But they start to develop fibrous tissue in between the myocardial fibers, which you hopefully will never ever do, right? And eventually the fibrous tissue gives way, no infarction, nothing, it's just the fibrous tissue between the fibers, and suddenly the heart does this. It explodes, right? What do you do with somebody like this, right? How do you treat this? He knows he's got it. He knows his 3 girls have it, because he's got 3 girl children, you know, and they've all got Flamen C, and the very bad variant of it. The cardiologist said, well, perhaps the best thing to do is to put him on beta blockers. We'll do a cardiac echo. His cardiac echo is already down to 32, and he's now, how old is he? 41 years old, 1984, right? He's 41, right? He knows he has it. He knows he's got fibrous tissue in his heart. What does a cardiologist do? The only solution to this disease is what? The heart transplant, right? You can't do anything about this fibrous tissue forming between the muscles of your heart. Sure, we can give him CoQ10, we can give him all sorts of things, but in effect, one day, this guy could suddenly die for no apparent reason to anybody else in the world. If you want to treat sudden deaths, beta blockers will slow down your heart, right? They will reduce the cardiac hypertrophy and even perhaps the fibrosis, right? They will try and stop fibrillation happening, right? Especially AF. They might stop ventricular arrhythmias, right? Because the heart is running at a slower rate, so less likely to get into VT and VF. Again, they stop the variability in heart rates on exercise. Again, they increase baroreflex sensitivity, and you reduce the risk of myocardial infarction. But this guy's problem is not myocardial infarction at all. Again, you can do things like putting in a defibrillator, right? So if they do develop the dysrhythmia, right, then hopefully you can pace them. But this doesn't stop the heart exploding at the same time, right? You can put them on ACE inhibitors, right, for example, right? Again, you reduce the cardiac hypertrophy and fibrosis, you stop fatal arrhythmias happening, you stop the variability in the heart rate. And if they're in renal failure and they need dialysis, then okay, you make sure that you use low potassium dialysis material, and you stop rapid electrolyte shifts during dialysis. And this doesn't apply to most people at all, especially in young. So all of these things, ACE inhibitors, for example, are better than ARBs. But this comes from the French, the Centre d'Expertise Mort Subie. For those of you who know French, this is called the Center of Expertise in Sudden Death, and especially athletes. This is not something that happens only to humans. It happens with rabbits, for example, right? If a rabbit is chased by a dog or a fox, the rabbit will suddenly die. Not because it's exerted itself. Sometimes even light noises from children, for example, who kill as pets, right? The loud noise from the child can actually kill a rabbit. Okay, the other example, it can be a viral infection, a viral myocarditis. Again, there is a particular viral infection that causes this. But again, horses, thoroughbred horses, worth millions of dollars, right? Great champions have dropped dead suddenly. Why? It doesn't matter. They've been spooked by fire or thunder, or even a wolf, for example, chasing a horse. The horse will die suddenly for no apparent reason, right? They haven't been running for very long. Sometimes the great fear will cause them to die. Again, if you look back at the literature over the last 60, 70, 80 years in medicine, there are some things called voodoo deaths, for example, right? I don't know what the equivalent is in Indonesia with your shamans and your rangdas and everything else, right? I don't know what it is, right? But, for example, in Australia, we have something of Aboriginals called pointing the bow. They point the bow at you, and you now have to leave your community because you've been outed, because you've done something bad. You've killed somebody, for example. Those people will often die within 24 hours, even though previously they've been very healthy people running around. Why? Again, the extreme trauma of just sitting out there. The Maoris in New Zealand, something called tapu. Tapu is also a piece of bark that they give you as presents. But tapu can be good or bad. And if the tapu has been put on you, in Haiti, right, for example, they've got something called voodoo. The little dolls with the pins. They put the pins in you and you die. Why do they put the pins in you? Why does it kill you? Nobody knows, but it has to do something with extreme fear. Again, in the Congo, it's called the wrath of the medicine men. So people die sometimes just because of being fearful. And I'll give you some cases of this. What's the mechanism? So this has been going on for thousands of years, you know. This is as I said, we do not know what we do not know, right? So basically we have the problem that, like the dodo, this is never going to, unlike the dodo, it's never going to be extinct. Some of them with the intense catecholamine, and I've seen it in my wife recently when she had her stroke, goes to intensive care. Her blood pressure is normal 90 on 60 anyway, but they want to bring her cerebral blood flow up. So she ends up on a noradrenaline and a methylamininol infusion, right? This whacks the heart and then whacks the heart, and she suddenly does Takotsubo cardiomyopathy, right? Which we then have to treat with even more catecholamines and then even more things to hold her blood pressure up. So when you go to a cardiac arrest and they tell you, what's the dose of adrenaline? And what's the dose of adrenaline? What is the dose of adrenaline in a cardiac arrest? Can anybody tell me? Nobody. What do you do when you go to cardiac arrest? How much adrenaline do you give? Come on, quickly. This is something that you need to know. She's just arresting. Aren't you going to do anything for her? The dose of adrenaline is enough. There is no dose of adrenaline. Enough until we get the cardiac rhythm back. It doesn't matter what you give. But the price you pay for that huge dose of adrenaline, they do get a cardiomyopathy sometimes. Again, myocardial, cardiac necrosis, cells can actually die from the stuff that we give them every day, that we use in cardiac. Sometimes it's reversible, and sometimes they die. This comes from, in 1942, from this author writing about voodoo death. He wasn't an anesthetist, he was an anthropologist. And he tried to explain why people die from voodoo, why putting needles in people kills them. This is the New York chest pain study. Disturbance. Severe, of course, means different things to different people. And I'll show you, right? What does it cause? They presented to a New York, and it was published in the New England Journal of Medicine, 2005. Left ventricular ejection fraction was 20%. So these guys are severe heart failure. They're in frank pulmonary edema with frothing, with coming out of their mouths. The catecholamine levels were very, very high. Most of them, these 19 people, eventually returned to normal. What was severe, catastrophic disturbance? What was the emotional disturbance in the place? Look at the 19 patients. Some of them were smokers, some of them had high cholesterols, some of them were hypertensive, right? Some of them had nothing at all wrong with them. And what are mother's death, a car accident, a reunion, surprise reunion with friends or family, a surprise party, everybody jumps out, happy birthday to you, and suddenly, boom, they drop dead, or they go into pulmonary edema, right? A friend's death, all of them, a court case, a fear of choking, an armed robbery, a son's death, some bit of tragic news. All of them were, in fact, not related to anything cardiac at all, right? And yet they get trouble. In pregnancy, it's even worse, because now in pregnancy, we're dealing not only with two genders, we're now dealing with three genders. The third gender, of course, LGBT, whatever. A pregnant woman does same anatomic, immunological, pathological, or psychological sex of her gender. She's now got a new gender, right? And it involves two people, the mum and the baby. So it's two patients with three genders, right? It's a very, very interesting phenomenon, pregnancy. Labor and delivery, even worse than that, right? Because suddenly the hemodynamic changes are happening very fast. And so a new cardiac disease. What is this new cardiac disease of pregnancy? What has made it a new cardiac disease? The fact that in the last 15 years, 20 years, perhaps even longer, we have maybe measuring echocardiography. We've been doing echocardiography. We now can measure transcutaneously, esophageally, right, with a toe, with a transesophageal echocardiography. We can actually see what's happening in the heart. So we have a new disease, and this is called stress-induced cardiomyopathy, right? And we can now, using sophisticated imaging at the side, we now have a bravely new disease. So the temperature is changing, and even the spectrum happens. Some functional recovery, and some will die. What you call it doesn't really matter, whether you call it voodoo death in the 1940s, whether you call it the left ventricular apical ballooning syndrome, whether you call it the broken heart syndrome, and we'll exclude sepsis, because in fact, sepsis is a very strange phenomenon, where you can still get the cardiomyopathies you get here, but with a completely different sort of mechanism. So again, sepsis, see, bad news. stress cardiomyopathy. Can anybody tell me what Taketsubo means? What is Taketsubo? Why is it Taketsubo? The name Pan, right? As I today, to their own vices, physicians use familiar devices. If we have the facility of doing echoes, and of course in obstetrics we have a great facility for doing echocardiography if we wanted to. They've got hundreds of sheets for everything, you know, of device. For looking for a nowadays, you have to bring a machine. To putting a nerve block and uses these sort of devices every day of our lives. So has made a great difference. But this is what Taket is about. Octopus strap, right? This is the shape of an octopus strap, right? Described in 1990, and that's the name, Takotsubo. Why is it called that? Because when you do an echocardiography on these patients, in say something like broken heart syndrome, which is left apical ballooning syndrome, another name for the same thing, right? We do not know, I've said this twice already this morning, we do not know what we do not know. And that comes from Wayne Bennett, but it's a very important principle of medicine. Don't forget that, right? Do not forget, ever, that we have a problem, a real, right? In that we often think we're very smart, and we are very smart, but we still have this great limitation, what we don't know. Now, I want to talk about stress-induced cardiomyopathy, or Takotsubo, and I want to show you a couple of case histories. First of all, it is usually a transient systemic action, where the heart becomes a bit like that octopus strap I showed you. There is no coronary artery disease in any of these patients. They're not sick patients in the first place. They're not infarcting on you, all right? The presentation, the to acute coronary artery syndrome, shortness of breath, frank pulmonary edema sometimes, but are very small compared to the degree of dysfunction. So the dysfunction is much worse than would be suggested as in an infarct with troponin measurements. The findings are left apical ballooning. I'll show you this in a moment. Several other variant patterns can occur. In fact, there is even now a new disease called reverse Takotsubo, where instead of the chart looking like an octopus, like that, it actually looks like a wave. I'll show you. Applications at the time are cardiogenic shock, pulmonary edema, ventricular dysrhythmias, and sometimes, because of the left ventricle being completely whacked out, you get mitral valve incompetence, even a valve. The onset of symptom is emotional. The trigger is often severe stress of some sort. And pregnancy and labor are good places for stress. 30 years ago, known as broken heart syndrome, it's known as left ventricular apical ballooning, stress-induced cardiomyopathy. It's basically a sometimes transient systolic dysfunction. My wife spent about 3 weeks, and even now she's still on a bit of anti-heart failure medication. She doesn't need it. That's a different story. And basically, the name, as I said, from the octopus strap. So now I want to show you 160 deaths. Before I showed you 19 people who recovered completely. This Jewish paper, deaths. Life event, and I don't care about my life. I give up. That's it. you know, and they then go into heart failure and die. So then, what are the causes, for example, normally? If you had a cardiac death in pregnancy or at term, labor or delivery, what has your patient died of normally? Well, we all have a long list of things. For example, the one culprit that probably doesn't deserve it as much is amniotic fluid embolism, right? We think that they've got embolism, but unless you prove it to me, as soon as somebody mentions amniotic fluid, boom, my ears go like that. Boom. Because I know that sometimes it's an esophageal intubation from anesthesia that caused the death. It has nothing to do with amniotic fluid, but amniotic fluid embolism is very hard to prove, right? So normal causes of sudden cardiac arrest. Normally it's sometimes of air, spasm now we're talking about, as opposed to in your coronary arteries, acute coronary artery syndrome. Sometimes a total spinal, for example, right? Inadvertent. You've given an epidural dose of local anesthetics into the subarachnoid space, and now they get a total spinal and die on you, right? Anaphylaxis. Hemorrhagic dose in preeclampsia, for example, the question we just had asked this morning, right? Sometimes even just a to the head, right? And that's the cause. And we have this thing called vagal. What does vagal mean? Again, it's this exactly the tubo to the stuff. And then all the these we have all these cardiomyopathies, all of which I've mentioned before. Peripartum, stress-induced cardiomyopathy, acute coronary artery syndrome, same as there, viral cardiomyopathy. We saw some in COVID of viral cardiomyopathies, right? HOCM, hypertrophic obstruction, and then all the dilated cardiomyopathies, of which there are very many variants. Myocardial stunning, what is the basis of this? How does it happen? And there have been some papers, not many, that have been written, right? This is the neurohumoral features of myocardial stunning due to sudden emotional stress. And why is it so different from one person to the next? So the pictures are entirely the same, but the mechanisms are completely different so spot the difference is not that hard with this disease, right? Again, Takotsubo and the anesthesia. Sure, plenty of case reports. Now let's try to answer some specific questions. Why does it happen? What have we done to contribute to it? What have we done to stop it? What have we anticipated and then tried to actually avoid it? So really, it doesn't all the good heads in the department together, right? It is very hard to answer. So there's suddenly, look what happens in systole. Suddenly, you get this weakness in the middle of the heart, and as you can see, it looks like your octopus strap, which is known as the Takotsubo. So this is cardiac function and sometimes MRI assessment, right, with stress cardiomyopathy. This is at the time the patient was admitted to a hospital. Now let me give you some stories, basically, right? She had hypertension before she comes in. She developed gestational diabetes, and so we had to start her on insulin. And she had an anxiety disorder of her own. She used to get panic attacks. She can't get onto a plane. She gets claustrophobic and has to be not that middle seat, this seat and not that middle seat. Why? Because sometimes she has to just get out quickly, Okay? Otherwise, she's fine. The CMP again with 20. She has 800 mils of Hartmann's, as we do for most cesarean sections. So this patient is having a combined spinal epidural for Caesar. At the end, right? At the end of the anesthesia before the blood pressure, high blood pressure of 200, perhaps aided by the fact that somebody's given her something to stop the blood pressure dropping after the CSC. She becomes very, very sweaty. She's pouring sweat like crazy, and she gets short of breath. As soon as they put her in the left lateral position for her block, she develops shortness of breath and desaturates to 70 on the oximetry. She has frank pulmonary edema, not from my hospital. Of course, we always say this, nothing happens in my hospital. All my hospitals are perfect. All my hospital patients are perfect. So always in some other hospital, all right? But she develops rapidly into an asystolic arrest. They start chest compression, they intubate her, and we deliver, she's now dying, basically. So we deliver the baby, and the baby was a little baby girl, and she's got good APGAR scores. The baby's all right, but mom is in big trouble. Right? And this is chest X-ray, right? Stage C, frank pulmonary, not at all. We continue resuscitation 40 minutes, and we get spontaneous circulation back. 3 attempts at defibrillation. She receives 7 milligrams of IV adrenaline in this, right? So, cardiogram shows moderate global left ventricular dysfunction, mitral regurgitation. Typical picture of Takotsubo, the 12-lead ECG, sinus tachycardia, no, and the ECG chest X-ray, as I've shown you a few seconds ago, and it's normal, right? So this patient has not arrested because of an infarct. This patient is not arrested but it is due to something like Takotsubo. This is the stress echo for the patient, and you can see the left ventricle is mildly dilated, the severe global dysfunction, but the right ventricle is normal in size. Again, these are the active stress cardiomyopathy is now diagnosed, and this is done with a TOW, post-resuscitation, and you can see there's severe central mitral regurgitation and acute left ventricular dilatation. So the left ventricle is grossly dilated. The ECG, not terribly remarkable, sinus tachy, and this was done on day 2, and this is exactly after resuscitation, and this is day 2, and you can see there's not much changes, and really, this is not an electrical problem of the heart. The progress in ICU to ICU goes with high infusion at 0.4 microspectrogram per minute, but on day 2, we can her off successfully of all 9 inotropes, and she keeps her cardiac output. Repeat echocardiography, only marginal improvement really, and ECG is, troponins remain normal. The same thing now being done at day 6. A transthoracic now, not a TOW. Again, left ventricle mildly dilated, moderate impairment of function, and moderate now mitral regurgitation. So things in the heart are now starting to improve. The meds should ACE inhibitors. Starts developing of the face, and now she's in intensive. Beta blockers are being increased all the time. Now with brain evidence of severe hypoxic brain damage. on day 6, do femoral brainstem testing, and she's basically brain dead. All right. So, and life support is we took the organs for transplantation, but life support had to be ceased. The brain on day 5 looks like this. It is terrible. You've got all loss of gray-white matter differentiation, right? There's actually subarachnoid hemorrhage, but it's all the brain now. All you have here is a brain which is completely hypoxic. It's dead. There is nothing there. And later on, we proved that there's not even stem function at all. You might ask, why has this been labeled as a panic attack, as a stress cardiomyopathy? Because why is it not, for example, PPCM? Why is it not peripartum cardiomyopathy that's caused this? And the reason is that PPCM, in order to say that this person has peripartum cardiomyopathy, right, you have to be able to prove what are known as the Hughes criteria. Which is more common? Is it PPCM or these new cardiomyopathies? And the answer, of course, is it doesn't matter, because often the effects are very much the same. But the advice we got from Oxford in England with these people, right, it's like this. If you have cardiac disease, do not fall in love, right? If you have this congenital disease, for example, if you fall in love, don't make love, right? If you make love, don't get pregnant. And if you get pregnant, don't have a child. That was Michael's diagnosis of how we treat these patients. And the answer is an impossibility, right, of all sorts for most people. The second patient is not a female, so not pregnant. It's a male, right? And this is an interesting guy, because this was the son of our theater porter, right? Who has big breasts. He's a big boy. Not quite a sumo wrestler, but anyway, a big boy. And he's got these big breasts that he wants to. Fair enough. So he goes to a private hospital. A bit of liposuction and subcutaneous mastectomy. He's fit well. He runs every day. No drug allergies. No medications. No family history of anesthetic complications. No steroid abuse. No drugs. Blood pressure is good. 100% on room air, saturation, and the induction goes well. And he gets given midazolam, propofol, fentanyl, Sevo for maintenance, for surgery, and everything goes very nicely. And then, right, this guy gets into, for no apparent, right, the NHS truly, that's me, drops the ball on him, right? Because prior to extubation, right, he gets some, and the heart rate drops from 45 to 30, give him 500 mics of atropine, right, no effect. He goes into asystole, he gets a precordial trump, an adrenaline 1 milligram, and has CPR for 1 minute, and he's resuscitated. He comes to my other hospital, not the Women's Hospital, but the Prince of Wales, right? But he brings up 60 mils of Prink 42. Then toxin. Quickly, he's got bilateral pulmonary edema, thorax. We give him some adrenaline infusion, again, not very impressive, and he goes to intensive care on PEEP, 16, basically, right? Drugs has done this? Don't know. Is it something else that's done this? Right? Is it the glycopyrrolate? I don't know. Is it the atropine? What is it? Right? Now, this, in fact, is not a case of Taketsubo, but a case of reverse Taketsubo, because the transthoracic echo shows global akinesia, which in this case has spared the apex and the posterior wall. This is not Taketsubo. It's not in the middle of the chamber that the problem is, and it's not at the apex. He develops AF, but again, reverse to ST changes, and the troponins do rise, even quite significantly, because there's obviously myocardial damage going on here, right? So all we can say is that we think that this is catecholamine-induced acute cardiomyopathy, but the pattern is the pattern of reverse Taketsubo. Again, this guy, I go through all of this, but basically the pattern changes as we go along. That's the transthoracic echo, day 2, day 3, and so on. We put a pulmonary artery catheter into him, and again, the numbers don't look too bad, except that initially they were very bad. Okay? Now, if about these 3 and 4, right? One is obstetrics at term in labor, and I'm coming to number 4 very shortly. Case 3, sorry, very shortly. There's no precipitating cause and becomes pre-arrest. Whereas a similar female, which is case 4, non-pregnant, an ENT patient, arrest, ICU admission, and rapid recovery. So not all of them die, you see. Some of them die and some of them do not. Case 3 is a very well-known person. I brought her into Australia myself. She's now a crack pathologist. I took care with her baby. She had as a register, panic attacks, a bit like one of those patients I showed you. 10 nights, 4 o'clock, so, and 4 oxytocin. 1 hour later, we get a met call. The rapid response team for the hospital of somebody who's in big trouble. Okay? Severe tachycardia, frag pulmonary edema, and severely dyspneic. Very short of breath. You know, I know that with some of you, we're getting to this point. We're going to sleep, the brain is full. So I'm going to cut the next bit. Can I be excused? My brain is full. Okay? She has an echo which shows typical Taketsubo. We started her on an infusion of esmolol. When I was in the United States, I was known as the esmolol man because I did most of the research on esmolol myself. Under the epidural I placed at 10 o'clock at night, she had cesarean section and everything went well. So, you know, this case 4, right? The case 4 is a different one. Well, it's 24 years old. She's going to another hospital for a septoplasty, right? And the surgeon injects pseudoephedrine, again, something that can cause tachycardia and so on, and probably put it straight into an artery somewhere. But it's somewhere in her nose anyway, perhaps even straight into the carotid. All right? Within 5 minutes, severe tachycardia, cardiac arrest, successful resuscitation, but we have cardiogenic going for a few more days, and the echo shows again an ejection fraction of 20 or less, and a Taketsubo picture. I bring you back to that original slide. Used cars, they look like. Before it was attributed to sympathetic or damage to cardiac myocytes, microvascular dysfunction. The and complications are potentially catastrophic. People die with this. You must do something about it straight away. So if you look at sudden deaths in general populations, basically, large numbers of people doing the studies, but also large numbers of people involved here. The number of, this is the ones that have had sudden death witnessed or not witnessed as to the cause, right? A total of 385 patients on 3-year follow-ups, total of 72 deaths in that group, right? Bad news indeed. There's even been books written as tragic as patients. If you want literature, take a photo of that. There's hundreds of papers you don't have to worry about, to be honest. Of people worse off in pregnancy, yes. Again, the question about the obese is very important because obesity causing sudden cardiac death in women is much higher. This is Jakarta. Luckily in Bali, you don't get this level of pollution, but even air pollution in big cities, this is not Jakarta. It can spark sudden death in women, right, who just fall over in the streets from the air pollution. Again, light smoking in women, right? Light smoking. So is any smoking safe, right? The answer is no, never. So whenever you see somebody coming to your accident and emergency center, whether it be a pregnant woman, a male, a female, young, always keep all these lessons because if you look at the cause cancers are important. Heart disease is important. But if you look at the little batch here of people who are from 15 years old to about 45, sudden cardiac death ranks amongst these at an equal incidence. It's the same as all the other causes, right? It's the same as cancers. It's the same as accidents. It's the same as chronic lung disease and strokes, right? And while things like Alzheimer's don't happen down here, right, sudden deaths do happen, right? Again, when it comes to the pregnant population in developed countries, right, you can see the maternal deaths is going down very rapidly. Funnily enough, in the United States, it's actually rising again, right? But the maternal mortality includes that, for example, the blue one here is down there is Australia, right? This is Canada, Denmark, Germany, Ireland, the Netherlands, New Zealand, Norway, Switzerland, right? Sudden deaths are the same in almost all countries. So if you have somebody who has inordinate stress, go in quickly and get your guys to do a cardiac echo. At least you know what you're dealing with, hopefully, right? I remind you that a normal heart looks like this, and that's what the left ventricle looks like. It's that shape. With Taketsubo, it looks like this. The heart looks exactly like your octopus strap. And once again, terima kasih.
Thank you. Thank you for interesting and insightful topic presentation, Professor. Let me to make a little bit summary for this topic in bahasa. Jadi setelah dibicarakan dari Prof, kita memiliki sebuah insight baru gitu, di mana yang pertama disebut voodoo death. Voodoo death itu artinya ketika seseorang terkena kutukan, dia akan terpaku di otaknya dia bahwa dia akan segera mati. Jadi stres, dulu orang percaya bahwa kutukan itu membuat orang meninggal. Setelah kita bergerak ke zaman yang lebih modern, ternyata yang membuat dia meninggal mendadak itu adalah stres respon yang berlebihan. Gitu ya. Jadi kita percaya bahwa stres respon itu dapat mengakibatkan kardiomiopati atau sudden cardiac arrest tiba-tiba. Gitu. Setelah itu yang kedua dengan takusubo. Takusubo itu seperti perangkap gurita, jadi ya bentuk dari ventrikel kirinya itu dia membesar di bawah, sedangkan untuk outletnya itu dia mengecil, itu maksudnya. Artinya bisa terjadi kardiomiopati karena stress induced. Selama ini kita hanya memikirkan bahwa jika pasien yang terutama ibu hamil gitu mengalami sudden cardiac arrest, kita hanya bisa berkata bahwa oh ini air embolism gitu atau ini emboli ketuban. Ternyata stress induced itu pada pasien-pasien yang memiliki riwayat depresi, dia stres, mudah stres itu sangat tinggi terjadi risiko kardiomiopati pada pasien tersebut gitu ya. Jadi mungkin di sini peranan kita sebagai anestesi untuk mengendalikan respon stres pada pasien, memberikan kenyamanan. Setelah itu juga tidak mudah terburu-buru menyimpulkan suatu kondisi bahwa oh ini emboli gitu. Jadi kita perlu melihat kronologis dari case report yang sudah dijelaskan oleh profesor bahwa outcome-nya bagus sebenarnya, cuma beberapa kondisi itu memang membutuhkan waktu untuk pemulihan gitu ya. Jadi banyak hal yang membuat kondisi kardiomiopati, bahkan Takotsubo ini lebih kita nggak pernah tahu dia Takotsubo ini lebih sering apa nggak daripada PPCM gitu. Kita satu lagi case yang mirip adalah PPCM gitu. Kita selalu mengatakan bahwa pasiennya PPCM gitu. Apakah benar dia PPCM? Apakah muncul kardiomiopati ini karena ledakan sekali stress induced yang membuat dia terjadi kardiomiopati mendadak gitu. Jadi itu harus dibedakan antara PPCM dan juga Takotsubo ini gitu, atau yang disebut dengan mekanisme yang dijelaskan oleh voodoo death tersebut gitu. Jadi kesimpulannya bahwa kita sebagai mungkin anestesi, sebagai tenaga medis dan juga yang lain-lain itu perlu kita melakukan screening lebih awal tentang kondisi pasien, psikis pasien, setelah itu membuat kondisi nyaman sebelum tindakan operasi. Begitu. Oke, thank you Professor. We have a question session, maybe 2 question. There is another question. Maybe from me. I have a question.
Sneaky, sneaky.
Is there a way to for us to screening or prevent the voodoo death or Takotsubo, maybe stress induced cardiomyopathy in pregnant woman?
Yes, very easy. See, the hospital already has plenty of mechanism, equipment for doing cardiac echo. If you go to your cardiac department, they even have portable guys. We've got a guy called Super Cooper, and he travels around all day with his portable echocardiography machine, cardiac. And he's a cardiologist. He's not even a cardiac anesthetist or a cardiac surgeon. All you have to do is ring up cardiac and says, can we have a quick cardiac echo? So in order to make the diagnosis immediately, with this person, for example, at the women's hospital, which is in the same building, admittedly, or next door, right? We can always get an echo very fast. So if you want to make the diagnosis, not just a Takotsubo, but a bunch of other things as well. The first thing you need to do, as soon as you have a patient with pulmonary edema, get an echo. It'll probably always tell you the same thing. It'll probably tell you that the patient is in heart failure because either they've got a dilated cardiomyopathy or they've got HOCM, in which case the chambers are small, or it's a Takotsubo. So the answer to make diagnosis is yes, it's fast, but there's only one way to make it, and that's by getting an echo. On the operating table in cardiac, there's probably usually a toe in anyway, transesophageal echocardiography, right? They can tell immediately what's happening. In these patients, if you're stuck, just put a esophageal probe. By now they're intubated and ventilated anyway, right? And get a decent echocardiography. And you can even then see the progress. As time goes on, you can do more and more and more and more, right? Studies on them. You can watch when they're getting better. You can see when they're getting worse. So diagnosis is actually very simple nowadays. In fact, the new cardiomyopathy really exists precisely because we have a diagnosis, a mechanism for making a diagnosis quickly. Don't bother with troponins. Don't bother with taking bloods on these patients, apart from using those for ventilating them well and so on. Just get an echo.
Okay, thank you, Professor. Maybe we have another question from the audience.
They're all asleep right now. Don't worry.
Maybe we will look in webinar in our YouTube first before
we won't take any more questions, but it's become customary over here for all of you now to come to the front and we'll take a photograph so that I can add it to my collection every year of the people who were here at the lecture in person. Is that all right with you guys? Can we bring everybody in the front and you can take a photograph, please? One photograph of all the people here.
Okay. I think there is no another question in our webinar YouTube,
Yes?
so we will close.
No, we'll get, yeah. So we can close them. Okay.
Sekarang saya akan kembalikan kepada MC untuk.
I'm afraid today as well, I'm going to have to leave you very quickly because I've left my wife, who still has a pelican on, and she's got the gastrostomy, and she's still at the hotel. She was going to come with me here and sit over there, but she decided that she's going to sit next to the pool instead. Okay, so I have to go. I have to leave you very fast. Okay, so let's get one photograph done, if you don't mind, and
as we come to the end of this enlightening guest lecture, I would like to express my heartfelt gratitude to all our moderators, sponsors, and attendees for making this event a resounding success. Today's insightful discussions and exchange of knowledge have truly enriched our understanding of obstetric anesthesia, both about Iraqs and also about Takotsubo cardiomyopathies. I hope you have found this lecture to be both informative and inspiring, and that you leave today with new ideas and perspectives to enhance your experience. To Professor Gatt, we would like to once again thank you for your dedication. Safe travels and see you at the reunion tomorrow. And for your ailing wife, we wish her the best of recovery so that she may recover soon. Thereby, we'll close today's event with Paramasanti Om Santi Santi Om.
Untuk peserta bisa maju ke depan ya, kita foto bareng. Untuk koas juga, presiden juga ya. Dia ada kenang-kenangan.
okay, guys, come on.